Hello everyone, welcome once again to another episode of Learning on SmartNursing. My name is Nurse Evie as usual, and today we want to try our hands on some NCLEX style questions on hyperkalemia. Okay, most at times you wonder if you actually grab anything at all after reading or going over your notes or studying, but trying your hands on questions actually helps build your confidence. Okay, and so today we want to look at a few NCLEX style questions and how we approach them. We will see some select all that apply, some priority questions, and some the best option out. Okay, so without wasting much time, let us just jump right into it. All right. So our first question reads: a patient has a serum potassium of 6.5 milliequivalents per liter. Which of the following is the normal potassium range? A patient has a serum potassium of 6.5. Okay, which of the following is the normal potassium range? In other words, is the 6.5 normal or not? Okay, so A, 2.5 to 4.5. These are the plausible answers. A is 2.5 to 4.5. B is 3.5 to 5.0. C is 4.0 to 6.5. And D is 5.0 to 7.0. Okay, as you can see the plausible answers on your screen. A is 2.5 to 4.5. B is 3.5 to 5.0. C is 4.0 to 6.5. And D is 5.0 to 7.0. So, what is the normal range? I think this is pretty straightforward, right? We already know from our previous lessons that the normal range of potassium is 3.5 to 5.0. So our answer obviously is B. This is just straightforward. This needs no strategy or anything. The straightforward answer is B. Our normal range is 3.5 to 5.0. Okay. So let's look at our second question. Which of the following ECG changes are seen in hyperkalemia? Which of the following ECG changes are seen in hyperkalemia? Now, from the tone of the question, you know this is what we call the select all that apply type of question. This is the select all that apply type of question, or simply the setter question. So you look through the plausible answers and pick as many answers possible that fit into your question or answers your question. So look at all the plausible answers and pick as many as you want. Whatever you think is correct or corresponds with the question, you pick them. All right. So here are the plausible answers. A is peaked T waves. B is flattened T waves. C is widened QRS complexes. And then D is ST elevation. So we have peaked T waves, flattened T waves, widened QRS complexes, and ST elevation. So which of these changes will you see? Okay, what do you think? We've gone over this. Our previous lesson spoke about ECG changes on hyperkalemia. So we know that it starts from somewhere, it progresses, through some stages and then gives you different kinds of presentations. So which one of this will apply? Right. Drum roll. What do you think? So our answers are A and C, and I'm sure you got that right. Right? It's A and C. A is the big T wave, so it starts with the big T waves, then it progresses to widen QRS complexes. You have your sine wave, and then you can have an AC storm. Now, in the plausible answers that we've been given, as you can see on your screen, A and C qualifies. Okay. When you look at B, which is hypokalemia, that is um, flattened T waves are mainly seen in hypokalemia. And ST elevations is not typical of any type of potassium presentation on ECG at all. Okay. So A is big T waves, C widened QRS complexes. That is what you will see with hyperkalemia. So our correct answers are A and C. All right. I hope you are doing well. How are you doing? I'm sure you are doing well. So let us look at another question. And it says here, which lab value may accompany hyperkalemia and chronic kidney disease? Which lab value may accompany hyperkalemia and chronic kidney disease? Okay, so your keywords here are your hyperkalemia and your chronic kidney disease. Which lab value may accompany hyperkalemia? So let's see. We have A, hypocalcemia, B, hypernatremia, C, metabolic acidosis, and D, hypomagnesemia. Okay, hypocalcemia, hypernatremia, metabolic acidosis, and hypomagnesemia. What do you think? Out of these lab values, which one may accompany hyperkalemia? And our obvious answer is metabolic acidosis. Okay, because even if you remember from our studies in metabolic acidosis and even in hyperkalemia, you know that acidosis causes hyperkalemia by shifting the potassium from the cells into the bloodstream. Okay, it alters the membrane, it interferes with the ATPase pump, and so potassium, which is supposed to be inside the cells, finds its way into the blood through some cascade of events. And that is why we always say that if somebody has chronic kidney disease, always assume that they have, hyperkalemia. And metabolic acidosis is very common with chronic kidney disease. Okay, so for hyperkalemia in chronic kidney disease, it will be accompanied by what? Metabolic acidosis. Okay, so acidosis shifts potassium from the cells into the blood. Then A, B, and D, which is hypocalcemia, hypernatremia, hypomagnesemia, have no relations with hyperkalemia at all. Okay, so hyperkalemia always goes with metabolic acidosis. All right, let's look at another question. Okay, which medication is used to stabilize the heart in hyperkalemia? Okay, which medication is used to stabilize the heart in hyperkalemia? Let's see. A is sodium bicarbonate. B is calcium gluconate. C is insulin, and D is furosemide. So we have sodium bicarbonate, calcium gluconate, insulin, and furosemide. Which of this is used to stabilize the heart in hyperkalemia? Now, the question you should be asking yourself is, can you use all these medications in the treatment of hyperkalemia? And the big answer is yes. So this type of question is like select the most appropriate, okay? Like choose the best of all, okay? That can stabilize the heart. So the keywords in your question here are hyperkalemia and stabilization of the heart. So which of these medications can you use to stabilize the heart? And what do you think? What do you think? Sodium bicarbonate can be used in hyperkalemia, right? Because of the acidosis. Okay, because of acidosis that comes with it, you will have to use sodium bicarbonate to buffer the acidosis there, don't you think? You will also use calcium gluconate. You will also use insulin and furosemide. But which of them stabilizes the heart? And the answer is calcium gluconate. I'm sure you know that. That is what we always say, that calcium gluconate is your handy medication, the number one drug that you should have. If that is the only medication you have, it's even better. If you have all others and you don't have calcium gluconate, I don't think you will help your patient much. But if you have calcium gluconate and you don't have the others, you can buy some time with that and then you get the others. So calcium gluconate is number one. That is what stabilizes your heart. So our answer here is B, calcium gluconate. Okay. Now, question number 5. Insulin is administered to a patient with hyperkalemia. Why is dextrose also given? Do you remember our CBK drop? Insulin is given in hyperkalemia. Why is dextrose also given in addition to the insulin? Now, the plausible answers are A, to prevent hyperglycemia, B, to prevent hypoglycemia, C, to increase potassium shift, and D, to stabilize the ECG. To prevent hyperglycemia, to prevent hypoglycemia, to increase potassium shift, and to stabilize ECG. So which is the reason why dextrose is given in addition to the insulin? All right, we know the answer, don't we? Insulin causes hypoglycemia, and we don't want that. So we will give dextrose, preferably 50%, 50 mils or 50% dextrose, to prevent that hypoglycemia that the insulin will cause. Right? Okay, so our answer here is B, to prevent hypoglycemia. Okay. Our next question. Which medications increase potassium and may worsen hyperkalemia? Select all that apply. Another SATA question. Which medication increase potassium and may worsen hyperkalemia? We have A, ACE inhibitors, B, potassium sparing diuretics, C, beta blockers, D, loop diuretics, and E, NSAIDs. So we have ACE inhibitors, potassium sparing diuretics, beta blockers, loop diuretics, and NSAIDs. Which one of these may cause hyperkalemia and needs to be questioned if it's prescribed for a patient already diagnosed with hyperkalemia or has the risk of developing hyperkalemia? What do you think? Out of our plausible answers, as you can see on your screen. Okay, so you realize that A, B, C, and E increases potassium. Are ACE inhibitors, reduces potassium excretion. Okay, potassium sparing diuretics, obviously it's potassium sparing, so it will spare potassium from coming out of the system, so it will worsen the blood level of potassium that you have. Then beta blockers, they reduce the cellular uptake of potassium. Okay, so ACE inhibitors will reduce potassium excretion. Potassium sparing will also retain potassium in your system. Then your beta blockers, they'll reduce cellular uptake of potassium. NSAIDs reduce renal potassium excretion. NSAIDs reduce renal potassium excretion. And then your loop diuretics, obviously, they don't cause any problem. They increase your potassium. That is why when we're giving diuretics in the management of hyperkalemia, we prefer loop diuretics. They allow potassium to be excreted. So what this is telling you is these medications are contraindicated in a patient being managed with hyperkalemia. You need to watch it. Okay, you need to constantly monitor blood values. Okay, or if possible, just avoid them totally. ACE inhibitors, because they will reduce potassium excretion. Okay, your potassium sparing diuretics, already from the name it tells you that it's sparing potassium, so there's no need even going near. Okay, and then your beta blockers, they reduce cellular uptake. We know potassium is supposed to be cellulized. It is supposed to be the main cellular electrolyte. So if there is reduction in potassium cellular uptake, then it's going to be retained in the blood. And then something like NSAIDs also reduces renal excretion of potassium. So NSAIDs, ACE inhibitors with potassium sparing diuretics, and then your beta blockers are to be avoided in any patient that is suspected of having hyperkalemia or have the risk. Or for example, in chronic kidney disease, you need to avoid this type of medication because it will lead obviously to hyperkalemia or worsen it. All right. How have you been doing so far? I mean, if you've watched this video to this point, then it is your first time. Why don't you give us a like? Okay, subscribe to this channel and let us keep giving you, content like this. Okay. All right. I think we can have one more. Let's look at one more question. Which intervention removes potassium from the body? So this is talking about the management. So which of the interventions remove potassium? We know that some remove it, some cause cellular uptakes, okay, and all that. So which of the interventions, when you give it, removes potassium from the body? A. When you give calcium gluconate. B. When you give chiasilate. C. When you give insulin. And D. When you give albuterol. Which one of them removes potassium from the body? So we know that calcium gluconate doesn't really affect your potassium. It stabilizes your heart. It actually just guards the heart against hyperkalemia. Okay, so it can't be calcium gluconate. How about chiasilate? We know what chiasilate does, right? It binds the potassium in your gut and then excretes it in your stool. So, what do you think? Let's keep going. And insulin, what does it do? Insulin actually enhances the cellular uptake. It shifts the potassium from the blood into the cells. So does it take it out? Okay. And then albuterol. What does albuterol does? Albuterol also helps to shift the potassium. Okay, so from our plausible answers, the correct answer is B. It is only chiasilate that causes excretion of the potassium from the body. Now that is not to say that the other interventions do not help in managing. They do help, just that the mechanism of action is different. They have their ways of doing it. Calcium gluconate will stabilize the heart. The others, apart from chiasilate, will cause a shift of potassium from the blood into the cells. Okay, so our correct answer here is B. Okay, chiasilate is the one that binds potassium in the gut and then causes its excretion out of the body. Okay, let's look at another question. A patient's potassium remains at 7.2 despite medications. The provider orders emergency dialysis. Why? Question again. A patient's potassium remains at 7.2 despite medications, and the provider orders emergency dialysis. Why? In other words, what are the indications of dialysis? Remember from our CBK drug, dialysis is the last resort. So what are the indications? A. Dialysis stabilizes cardiac membranes. B. Dialysis lowers potassium quickly. C. Dialysis is less invasive than insulin. And D. Dialysis treats hypokalemia. This is obviously okay. It's hyper we are dealing with here, and it's nothing has nothing to do with hypokalemia. So D is obviously out. It is less invasive than insulin. Is that true? It lowers potassium quickly and it stabilizes the cardiac membrane. Does it? Does it stabilize the cardiac membranes? What do you think our correct answer is? Our answer here is B. It lowers it quickly. Now, when you remember the indications, one of the indications is the refractory type of hyperkalemia. Okay, the hyperkalemia that is persisting even after treatment. And from our question, it tells you that it remains at 7.2 despite medications. Okay, and you know that the dialysis it's a much more invasive one that goes directly into the bloodstream and then takes the potassium out quickly. Okay, because it's that invasive, it comes with some complications and side effects which you probably want to avoid, and you use it only when all others, all other interventions are not working. So that is for dialysis. Okay. So our correct answer here is B. It removes the potassium from the blood quickly. Okay. And it is essential in refractory or severe hyperkalemia. All other possible answers are not right. How about we go into some diet questions? Which food should a patient with hyperkalemia avoid? Which food should a patient with hyperkalemia avoid? Select all that apply. Which food should a patient with hyperkalemia avoid? Select all that apply. A. Oranges. B. Bananas. C. Rice. D. Spinach. E. Tomatoes. In other words, which of these substances stated here contain potassium values? Because you have hyperkalemia, you want to avoid any food that will worsen it, right? So, which are the foods here that contain? I mean, tomatoes as well. They have potassium. They are rich in potassium. So when you want to avoid any food that will probably worsen your situation, then you want to avoid this type of food. Okay, let's do one last question for this session, and then maybe depending on your response, you might have another session of questions. Okay, so a patient asks why they need to avoid salt substitutes. A patient asks why they need to avoid salt substitutes. What is your best response? A. They contain sodium. B. They contain potassium. They taste bad and they increase calcium. What is your best response? Okay, so this one is select the best, alright? They contain sodium, they contain potassium, they taste bad, and they increase calcium. Why should a patient with hyperkalemia avoid salt substitutes? What is your answer? Our answer here is B. They contain potassium. Okay. Our rationale is that many salt substitutes like potassium chloride, you can already see potassium there. This is not sodium chloride, this is potassium chloride. So if it's not salt, if it's not a sodium chloride and it's a substitute, most of them contain potassium. Okay, so you need to avoid them. Okay, this brings us to the end of this session. Thank you so much for watching. Thank you so much for sticking and staying with us. Like, share, subscribe, and we'll see you in another video. Bye bye.